Good morning, and thank everyone for being here with us today. And special thanks to Merck company for organizing this event and for inviting me to have this opportunity to share with you our work in WinMake. And my topic is about high responder, as you already know. So in clinical real life, we have diagnosis criteria. We all know about Rotterdam criteria that we apply in our center as well. And if we have a two between three criteria, we have a diagnosis of one patient with PCOS. We have a classification of PCOS patient in four types as well. Type 1 with all three criteria. Type 2 characterized by anovulation and high androgen level. Type 3 with PCOM and high androgen level. And type 4 PCOM and anovulation. And we all know that we have a strong association between PCOS and infertility, and there are some reasons why PCOS patients have infertility. We know that more of our PCOS patients had anovulatory, so ovulation is very important for fertility. So if PCOS patients have anovulatory cycle, they cannot be pregnant. And otherwise, we all know that when we do IVF cycle, PCOS patient, we obtain maybe many oocytes, but the quality of the oocyte, the competence of the oocyte are poor. And after that, we also know about the receptivity of the endometrium in IVF cycle with PCOS patient. Normally, we have a high level of estrogen, but also a high level of progesterone. So this high level of estrogen and progesterone could impair the receptivity of the endometrium. And we, in PCOS patients, we could also have impaired implantation when we put back the embryo inside the endometrium cavity because of the high level of anti-insulin. And in terms of pregnancy follow-up, we all know that PCOS patients could have more complications during pregnancy, like miscarriage or preterm birth, in comparison with no PCOS patient. And in terms of PCOS patient and infertility, we apply guidelines from the consensus guideline and international guideline for PCOS patient. We all know that the first line therapy for PCOS patient in terms of ovarian induction is we use clomiphene citrate. And now we are shifting more to aromatase inhibitor. And in second line therapy for PCOS patients, we use laparoscopic ovarian drilling. In fact, we are doing it very rarely in Vietnam or in our center, and we use mainly gonadotropin. And in the third line, we use IVF. And in terms to improve the outcome of PCOS patients before starting the IVF cycle, we have a multidisciplinary team to take care of the patient. In terms, we give counsel about weight loss in overweight patients. And in our population, we have a small percentage of PCOS patients with overweight. But if we have overweight PCOS patients, we send them to psychology, to nutritionists. So we have a multidisciplinary team to take care of this PCOS overweight patient. And we also prescribe metformin in terms to improve insulin sensibility and ovarian drilling in some cases. And we also give supplement with myoinositol that we know that there are some studies that demonstrated that myoinositol could improve the egg, the oocyte quality before IVF cycle. And we apply this protocol to prevent OSS in our clinic. We use on with hyperresponder patients. We apply on antagonist protocol and low gonadotropin starting dose. And normally we start with 150 units per day and agonist trigger for on free zone. And we also prescribe cabergoline normally 3 to 4 days immediately after oocyte pickup in terms to reduce the risk for OSS. And we, after that, after the ovarian stimulation, we perform single blastocyst transfer. And this our data, our result in 2 years, in 2021 and 2022, we have 516 cases, and in 2021, from them, 125 cases, that's 24% of all our patients are PCOS patients. And in 2022, due to COVID, we have less cases. We have 280 cycles with 76 cases with PCOS. That means 27% of our patients were PCOS. And in terms of outcome, we have some parameters about chemical pregnancy rate, clinical pregnancy rate, and multiple pregnancy rate. And we are a center that's ATAC certified, so we follow the recommendation of the ATAC bodies to reduce the risk of multiple pregnancy. And with this protocol that we apply to all our PCOS patients, we have quite low complication risk of OSS. In 2021, we have only 4% of them, and in 2022, only one case with severe OSS syndrome. So we define OSS severe syndrome when the patient requires hospitalization. So in this case, in 2022, we have only one case of OSS. So now I'm going to move to the second part of my talk about one case. I think that is quite interesting case, and I hope that this case will give you some learning. So this is an informatory case report of the symptom, sign, diagnosis, treatment, and follow-up of one case, and each patient is different, and experiences and treatment outcome in other patients may be different from those in the case report, of course. And we have this patient with primary infertility, obstetrics history, she's 0, and she has started medical history of colonization, BMI 25, and normal SSD done in 2021. And she was primary infertile for 1 year, and with a history of 2 IUI cycle failed. And when we look at the blood test result, she has high AMS, 10.6, and normal other parameters with normal sperm analysis. And the diagnosis is primary infertility due to PCOS. And her last period was in November 2022. And we start the stimulation, apply the protocol that we have for all high responder patients in our center. So she started the dose of 150 units per day for ovarian stimulation, and we monitor the cycle by blood test and ultrasound. We do it normally on day 5 or day 6. The first check, the first monitoring, the second monitoring on day 8, and the last monitoring on day 9. As we use antagonist protocol, so flexible antagonist protocol, we use cetrotide in this case. And just before the USI pickup schedule, the patient experienced abdominal pain, mainly in lower right quadrant, so she went to another hospital. She did not came to us. She went to another hospital because of her pain, and she was admitted to rule out appendicitis. They talked about appendicitis, and she was hospitalized for 2 days. And 2 days later, and she came to our clinic as scheduled for USI pickup, and she still had abdominal pain, but less severe. And just before the USI pickup, she was consulted, and she had abdominal pain with rebound tendonitis. And when we put the probe, we see free fluid in her abdominal cavity, both ovary increase inside a lot. Of course, she's PCOS, and after 9 days of stimulation, and with a lot of follicle, and on the right ovary, the follicle have less content inside. This is some ultrasound images you can see, especially in the right ovary, so the image is quite very blurred. So it's quite difficult to define one follicle from the other because of the blood content inside the follicle. In the left ovary, so the image is quite clear. So we saw a lot of free fluids seem to be blood in her cul-de-sac and also in her upper quadrant, in both quadrants. And we decided to perform, to continue with oocyte pickup. So oocyte pickup was done, which we harvested 11 oocytes on the left ovary, and we also aspirated around 500 milliliters of blood from her cul-de-sac. And the patient was transferred to operating theater for laparoscopy, and with the diagnosis of right ovary torsion. And in this patient, the symptoms started 2 days earlier. So when we came in her abdominal cavity, so the ovary torsion already with sign of necrosis. So that's why we decided to perform the right ovariectomy. So she's stable after the operation, and she was discharged 2 days later, and she got a frozen embryo transfer with single blastocyst transfer, and now she's ongoing pregnancy. So I have some key learnings from the case study. So we know that with proper protocol, OSS is rare nowadays, but it could be life-threatening. So it still be a concern for many IVF clinics. But when we apply a good protocol, so we have a very low risk of OSS, and pain caused by ovarian torsion could be misinterpreted by OSS. So in this patient, she did not have severe symptom of OSS. She had ovarian torsion, but as ovarian torsion is very rare in our practice, so we could misinterpret. So thus she has OSS, and we would protocol to prevent OSS. A free clinic OSS is possible. So that's its own. Thank you for your attention.